Auzubillahiminash-shaytanir-rajeem. Bismillahir-rahmanir-rahim. Today's talk is about the hypertension and beta blocker, and our today guest is Dr. Haroon Aziz Khan Babar. He is a professor of cardiology. Uh, he is also MRCP from Ireland, UK, and even FRCP from Edinburgh. He is also currently is working as a professor of cardiology and head of department of cardiology at National Medical College, National Medical University, Multan. Please, Dr. Haroon Aziz Khan Babar, sir. Please take up the session.
Assalamu alaikum. Bismillahirrahmanirrahim. Hypertension and beta blockers, long forgotten topic. एक ज़माना था कि 70s, 60s beta blockers were used to treat hypertension as early as 70s and 60s. Or up till 90s tak beta blockers used to be the first line drugs along with ACE inhibitors and etc. for treating beta blockers, for treating hypertension. But this paradigm changed and new drugs came in, ACE inhibitors, beta ARBs, calcium channel blockers. They were introduced for the treatment of hypertension. And even in guidelines, beta blockers went down to number 3 or 4th place in the treatment of hypertension alone. No doubt they are the first line drugs still in the case of ischemic heart disease and angina. But now there is a resurgence of beta blockers again in the last decade, especially drugs like Navivolol, which have come back for the treatment of hypertension. Let us see the role of beta blockers, their history, their classification, their pharmacology, their therapeutic roles, their side effects, etc. Next, please. As you all know that hypertension is a growing epidemic. In the year 2000, estimated number of adults with hypertension was 972 million in developing countries. And by 2025, this may reach up to 1.56 billion. So this is a large set of population which will be suffering from hypertension, especially essential hypertension. By current year 2020, cardiovascular disease may be the leading cause of death in the developing countries, and it is still the leading cause of death. Each year, at least 7.1 million people die as a result of raised blood pressure. Because this is our ignorance. Still, we are ignorant of the dangers of high blood pressure, of uncontrolled high blood pressure. And we still do not recognize that this is one of the silent killers which people ignore. And most of the people are unaware that they have hypertension. So these are few facts which should be brought before the audience, and also people should remember it in their mind that hypertension needs to be treated, needs to be controlled. Next, please. Hypertension contributes to lot of morbidity in the developing countries and also to mortality as well. Circulatory disease causes over 100,000 deaths per year, or 12% of all cause mortality. This is a big number. 18% of the adults suffer from high blood pressure. So this is a division between urban areas and rural areas. 1 in every 3 adults aged more than 45 suffer from essential hypertension. Look at this figure. This is also a big task. And less than 3% Pakistanis with hypertension have their BP controlled. So this is a very sorry state of affairs that at the moment, this is what the statistics show. But I don't fully agree with it. I think that less than 30% maybe 40% may be having well control of the BP. But this is what the figures show. Next, please. National survey continues to show substantial underdiagnosis, undertreatment, and poor rates of blood pressure control. This is what I already mentioned, that blood pressure control is being ignored by the masses, by the government, by the health agencies in our country. So we need to focus on this disease if we want to decrease the mortality and morbidity in our generations. CME programs for GPs on hypertension has shown to improve BP control. We are trying our best. And in some areas, we have succeeded in controlling blood pressure in Pakistan. Next. Well, most of you are aware of the rules of halves, which has been there for decades. That what we say that 50% of the people with hypertension are undiagnosed, 50% are diagnosed. In those which are diagnosed, 50% are untreated and 50% are treated. And in which people, in those people who are being treated even with medicines, still 50% are poorly treated. So this is the state of affairs. That even if people who are being treated, half of them never reach the goals which we need. That is 120 by 80 blood pressure, 120 systolic and 80 diastolic. Next. It has been shown that even if you reduce, what I was trying to tell was that such is the impact of even a mild decrease in blood pressure, that even if you decrease 2 mmHg decrease of blood pressure, you still get the results 7% reduction in the risk of ischemic heart disease mortality and 10% reduction in the risk of stroke mortality. So this is a quite substantial number. Next. Risk reduction by tight control. This is where we want to achieve our goals. A tight BP control, say less than 144 by 82, reduce the risk of diabetic complications compared with the less tight control of 154 by 87. This was one of the studies which shows UKPDS. Next. And also, early treatment is mandatory. Cardiovascular mortality risk doubles with each 20 by 10 mmHg decrease in deep blood pressure. It means that if there is a 20 systolic increase in blood pressure, the patient's mortality risk will double. Similarly, if there is a 10 mmHg increase in blood pressure in diastolic pressure, again it will double. So you can see here the figure how the mortality risk multiplies. Next. Next, please. 2018 ESC guidelines for the management of arterial hypertension. How we used to cater for it before and now. This was one of the 2017 guidelines and this is 2018's. So we usually, what is the initial treatment? What is the best treatment? The best treatment I always say is that please start with a non-pharmacological therapy if there is no end organ damage. If somebody has end organ damage, you will have to go on a pharmacological therapy as well. So what is non-pharmacological therapy? The patient should have an ideal weight, decrease the weight if the patient is obese or if the BMI is high. The patient should exercise at least half an hour to 40 minutes daily. A brisk walk will do it 5 days a week. And the person should concentrate on the diet. The diet should mostly consist of fruits and vegetables and legumes and lentils rather than on beef or other meats. So it is very particular to say that anybody who wants to control his blood pressure, they have to change their lifestyle, their eating habits. They have to control their weights. If they are smoking, they have to quit smoking. And if somebody is a diabetic, They have to control their blood sugar levels. Or if somebody has dyslipidemia, high cholesterol levels, they need to be controlled. So these are important things for the control of blood pressure, to attain the control of blood pressure as well as to decrease the morbidity and mortality of blood due to blood pressure. Let us come to the pharmacological therapy. The pharmacological therapy is you start with an ACE inhibitor or an ARB. And if still the blood pressure is up, you can add in a calcium channel blocker. And if still the blood pressure is up, then you go on to beta blockers, diuretics, etc. Let me say here that even in the first step, people who are above 50, they are usually given calcium channel blockers. They respond much better to calcium channel blockers as compared to the ACE inhibitors or ARBs, or even the black population. If still the blood pressure is not controlled, then you come to the triple or combinations of all these drugs which I have already mentioned. And still if the blood pressure is not controlled, then we add specialized diuretics like spironolactone, which contains aldactone, or even alpha blockers, or third line, fourth line beta blockers. Next, please. Guidelines eliminate the classification of pre-hypertension and divide it into the two levels. Elevated BP with a systolic blood pressure between 120 and 129 mmHg and diastolic less than 80 mmHg. This is a systolic blood pressure, isolated. Then stage 1 hypertension with systolic BP of 130 to 139 or a diastolic BP of 80 to 89. In adults at increased risk of heart failure, the optimal BP in those with hypertension should be less than 130 by 80. And even with people with diabetes or chronic kidney disease, the ideal BP should be less than 130 by 80. Next, please. Next slide. What are the WHO guidelines for hypertension? WHO says optimal is systolic BP less than 120 and diastolic lower than 80 mmHg. And the normal is systolic 120 to 129 mmHg and diastolic of 80 to 84 mmHg. High normal is counted as 130 to 139 systolic mmHg and diastolic of 85 to 89 mmHg. And grade 1 hypertension we call is systolic of 140 to 160 and diastolic of 90 to 99. Next, please. These were the figures of February 2019. So there is a central illustration, the comparison of American and European society definitions and the management of hypertension. Well, as a rule of the thumb, it is better to say, rather than to confuse the people, that all people, every adult should have a BP of less than 140 by 90. This is the cutting line. This is the upper line. All of these patients or people suffering from hypertension should ideally have less than 140 by 90. And moreover, it will be much better if they have 120 by 80, which is the desired blood pressure. So I don't think we should go into more of a confusing the people, because this is one of the figures which is showing nighttime mean blood pressure and office blood pressure and home BP, and usually we do it with the 24-hour ambulatory blood pressure monitoring. So people who are having resistant hypertension or people who don't respond to drugs properly, usually we put them on 24-hour ambulatory BP monitoring, and then we decide what should be done, or which medicine should be increased or which medicine should be added. So this is blood pressure BP monitoring. 24-hour ambulatory BP monitoring is one of the tools which is used nowadays not only for blood pressure control, but to see the effects of the drugs as well, which are being used to treat hypertension. Next. So ACC-AHA guidelines mention that all people with blood pressure of 130 mmHg have hypertension, and blood pressure should be lower than 130/80 in all. This is of 2019. Next. So recommended BP goals according to JNC 7, JNC 8, and 2017 ACC-AHA guidelines is that should be less than 140/90, as already mentioned. And even the ACC 2017 guidelines say it should be less than 130/80. So usually our consensus is that in diabetes and chronic kidney disease, the blood pressure should be less than 130/80. Next, please. Antihypertensive drug classes and their action sites. As you all know that blood pressure is equal to cardiac output and total peripheral resistance. So there are a number of drugs which are used as antihypertensive drug, and their classes are, as I already mentioned, ACE inhibitors, angiotensin receptor blockers, beta blockers. At one stage we were having direct renin inhibitors, but no longer we have at the moment in our armamentarium of the just direct renin inhibitors. It was launched sometimes back, but due to its some side effect profile, it was withdrawn. And even alpha blockers have been used in resistance cases. Calcium channel blockers, non-dihydropyridine, and all these drugs have been used for the treatment of hypertension. Vasodilators, diuretics. Next, please. So the classes of antihypertensive drugs, they still continue. Aldosterone receptor antagonists, especially people who are resistant to the treatment with the above drugs which have been mentioned. ACE inhibitors, ARBs, and then we can add these drugs, aldosterone receptor antagonist. Next, please. Next. How do you select your antihypertensive medication? The Birmingham Hypertensive Square, hypertension square for adults in drugs in the management of hypertension. The square may be approached from any corner. With first-line drugs chosen logically, the optimal second-line agents are immediately adjacent and indicated by the arrows. So if you have chosen beta blocker, somebody who has got high blood pressure and ischemic heart disease, of course, beta blockers are the drug of choice. Apart from already, which I have mentioned, non-pharmacological advice as well. And then you can add in thiazide diuretics, you can add in ACE inhibitors, you can add in calcium channel blockers, depending upon how much the patient has blood pressure and how much he has benefited. So the therapeutic strategy, for some time, the focus has been on initial monotherapy, followed by step-up approach. And the concept that what matters is to lower the blood pressure by whatever means. But now things have changed, and even we give multiple drugs for the control of hypertension, especially if somebody has got major risk factors, more than two major risk factors, or somebody has got a end organ damage, we may start with the two drug therapy. Multiple drug therapies can be used, 2 or 3 drugs can be used from the start even, in combination. Next, please. And of course, non-pharmacological therapy has already been mentioned. Next, please. So hypertension and beta blockers overview, we have mentioned a lot of data. We have seen a lot of data. And as you all know, that beta blockers are a class of drugs which not only controls the blood pressure, but essential for treating patients with coronary artery disease, patients who have atherosclerosis, because hypertension leads to atherosclerosis. patients who have LVH, left ventricle hypertrophy, which is again a bad prognostic sign. Anybody having myocardial infarction, arrhythmias. So beta blockers have shown to be superior to other drugs. In people who have ischemic heart disease, myocardial infarction, related arrhythmias, they have shown to decrease the mortality and morbidity. Next, please. So, history of cardiovascular indication development, more than 50 years of age, ischemic heart disease is one of the leading causes of death. More than 45 years of age, the beta blockers also have, as I mentioned, antihypertensive and anti-ischemic effect. And of course, they are being used for heart failure as well. And the drugs which we use usually for heart failure are carbidopa and Navivolol. And sometimes we even give a small dose of Bisperol. So all the studies have shown, meta-analysis has shown that these are the drug of choice for people with cardiac failure. Next, please. So the GNC recommendations, initial antihypertensive agents, this is started from GNC 1 and now we have come to GNC 8, which was published in 2014. And all these number of drugs, diuretics, again and again, and they have shown their worth, ACE inhibitors, as well as calcium channel blockers, and in many cases, beta blockers have also contributed because of the other risk profile and comorbidities. Next, please. So what are the concerns related to beta blockers? Those during hepatic or renal impairment, this is the most commonly asked question. Do they alter the lipid profile and glucose metabolism? Do they have effects on airway resistance? Do they cause peripheral vasoconstriction? Do they cause sexual dysfunction? Next, please. So this is beta 2, beta 1 selectivity ratio, human beta receptors in vitro. So if you compare these drugs, Bisperol stands quite high in all this beta blocker armory. So Bisperol has 19.6 fold higher affinity for the beta 1 receptor than the beta 2 receptors. So this has shown more, this is more and very selective beta blocker as compared to other beta blockers. Next. So of course, this shows the side effect profile is lower than other beta blockers. And in beta 1 selectivity in human myocardium, this has been compared to Navivolol. Navivolol's cardiac selectivity is limited to extensive metabolism and at doses of less than equal to 10 milligram, indicating that the cardiac selectivity is modest. But as compared to Bisperol, the Bisperol is very high cardiac selectivity. Next, please. Compared with the selected beta blockers, here you can see that what is the elimination route of these drugs. So still you can see that beta blockers are being used in liver problems, in kidney problems, and this is a safe drug to be used in chronic kidney disease as well as compared to other drugs, other beta blockers. Beta blocker is suitable for patients with comorbid hypertension 1 and 2, no effect on blood flow or vascular resistance of carotid or brachial circulations, but increase in arterial compliance. This role is associated with balanced renal and hepatic clearance. No dose adjustment necessary in patients with mild to moderate renal or hepatic dysfunction. And in the study of the Bisperol pharmacokinetic profile, it was demonstrated that about 50% of the parent drug was excreted in urine. The remaining 50% was metabolized. So Bisperol can be used in the comorbid hypertension. Next, please. Next. So again, we see the pharmacokinetics of and comparison of selected beta blockers. So you can see here the plasma elimination half-life of Bisperol, which is 10 to 12 hours. If you compare it with atenolol, atenolol needs to be taken at least twice daily, and the beta blocker Bisperol may be taken once daily. And metoprolol has the plasma elimination half-life less than this Bisperol as well as atenolol. So it is one of the drugs which has got a plasma elimination half-life of 10 to 12 hours. And there is more than 90% absorption, which is more than as compared to other beta blockers. And you can see here all the bioavailability is 90%. With other beta blockers do not reach to this limit. Active metabolism, metabolites are not there. So it's a balanced clearance as compared to other. Next, please. So a lot of plus points in the pharmacokinetics of Bisperol. Possible side effects and mechanism of action. Antihypertensive action of beta blockers is mediated by blockade of beta 1 receptors primarily. Beta 2 blockade does not add to the antihypertensive effect but may offset the BP lowering effect of beta 1 blockade by inhibiting vasodilator action of background circulating adrenaline. Beta 1 ISA diminish the antihypertensive action of beta blockers. Beta 2 blockade with non-selective agents, the propranolol, nadolol, and beta 1 ISA, they diminish it. So the sites and of the action are heart and brain, CNS, juxtaglomerular cells, peripheral vessels, remodeling occurs, vessel wall hypertrophy regresses, and also there is a resetting of baroreceptors. Next, please. What are the effects on metabolism? Bisperol has minimal effects on lipid and glucose metabolism, which was claimed earlier that the beta blockers they disturb the glucose metabolism and lipid metabolism. But this is a drug which has got minimal effects on the lipid and glucose metabolism. So it can be used safely even in patients with high cholesterol or diabetics. And especially when the need is there, you don't need to stop it. You have to consider Bisperol as the first line agent in treating patients who have ischemic heart disease and diabetes as well. Because you can see here from the figures, it's a minimal effect. Next, please. Effect of beta blockers on airway resistance has always been a controversy, and people are reluctant to give beta blockers to people with, of course, COPD and asthma. But beta 1 selectivity of Bisperol and the lung function in asthmatic hypertensives have shown the results otherwise. If you see here, this is a figure which shows that Bisperol is quite a safe drug. Next, please. Effect of beta blockers on airway resistance, beta 1 selectivity and lung functions in coronary patients with chronic obstructive airway disease, that is bronchitis. And here again, Bisperol stands out as compared to other beta blockers. It has got a better profile in patients with airway resistance. Next. 24-hour ambulatory blood pressure monitoring in patients receiving either Bisperol or atenolol. Here you can show the figure and see the figure that this is superior. Bisperol is superior to atenolol in controlling the 24-hour blood pressure in patients who were put on 24-hour ambulatory monitoring. Especially the nighttime blood pressures were much better controlled. Even the daytimes were much better controlled. Next, please. Next. Smokers and non-smokers with hypertension. Success rates after 8 weeks of individually titrated treatment. Look at the Bisperol and atenolol comparison. So this was much more tolerated in people with who are smoking. Next. Patients over the age of 60 with hypertension, systolic blood pressure, diastolic blood pressure, heart rate, much better figures as compared to atenolol, much better profile. Next. And this is a comparison of Bisperol versus Navivolol. Level of hormone of pituitary gland axis, pituitary gonadal axis, penile blood flow, sexual function in men, monotherapy and with Bisperol and Navivolol. You can see here the effect of Bisperol and Navivolol. So it is quite a promising drug, even if you consider it from the point of view of its effect on the vascular bed. Significantly increased concentration of testosterone, prolactin, lower levels of estradiol, improved vascular blood flow in penile arteries, did not worsen sexual function, and had more pronounced antihypertensive effect of Bisperol than that of Navivolol. Next. Next, please. Secondary prevention of myocardial infarction, beta blockers with or without intrinsic sympathomimetic activity. So here you can see the comparison. Beta blockers with ISA and beta blockers without ISA. So the reduction of mortality you can see yourself. Next. Effects of beta blockers in heart failure, long-term outcomes in congestive heart failure with COPD. This is a comparison of carvedilol and bisprolol, cumulative incidence, and look at with the time. So again, 40.8% better reduction with bisprolol compared to carvedilol. This is one of the charts which shows one of the studies which have shown this. Next. Next, please. Effects of beta blockers in heart failure. Bisprolol versus carvedilol, which is one of the carvedilol is the outstanding drug which is being used for cardiac failure, and it has been compared with bisprolol. Percentage of patients and functional class according to beta blocker, NYHA class. The improvement was significantly greater in the group titrated with bisprolol. So this was in 2009 study published. Next. Bisprolol versus carvedilol and metoprolol in heart failure patients. Again, these were landmark studies, Merit heart failure study, Copernicus with carvedilol, and Merit heart failure was with metoprolol, CBES2 with bisprolol, and look at the figures of minus 44% with bisprolol risk reduction of sudden death, relative risk reduction in mortality, and this has surpassed all other beta blockers which are being compared with bisprolol. Next, please. In the endothelial dysfunction effect of beta-1 adrenoreceptor blocker, beta bisprolol on endothelial dysfunction in patients with stable angina pectoris in combination with chronic obstructive pulmonary disease. Studied before and after 4-week treatment with bisprolol in 36 patients with angina, stable angina, and COPD using assessment of endothelial dependent vasodilatation and concentration of nitric oxide metabolites. Significant improvement of endothelial function was achieved due to bisprolol in 4-week treatment, which did not affect external respiratory function. Bisprolol is effective and safe drug in the treatment of stable angina combined with COPD even. Bisprolol can noticeably improve endothelial function. This is again a plus point in the priority for bisprolol. Next. And in the treatment of patients who have cardiac failure, who have COPD, who have stable angina, effects of levoprolol and bisprolol on blood pressure, vascular stiffness, and reflex sensitivity. Bisprolol achieved the greater reduction of peripheral resistance and vascular stiffness. Bisprolol may be useful in the hypertension with cardiac or vascular diseases who have advanced atherosclerotic changes and sympathetic nervous system activation. Next, please. Next. Next, next. Yes, we have seen all these. So in summary, I will like to summarize the action of Bisperol. The priority why we use Bisperol is that in all these beta blockers, which were used to treat early for hypertension and then for ischemic heart disease as well. And again, there is a resurgence of beta blockers for the treatment of hypertension. Beta blockers protect the heart at every stage of the cardiovascular continuum. Bisperol has a 19.64 higher affinity for beta 1 receptor than for the beta 2 receptors. Bisperol has minimal effect on lipids and glucose as compared to other beta blockers. It has minimal effect on lung function in coronary patients with chronic obstructive lung disease. It has superior antihypertensive effect than atenolol and nabivolol, and it has greater reduction of peripheral resistance and vascular stiffness, and it does not worsen sexual function, which is very important for the patient who comes to you and asks you about his sexual life. So again, it is noticeable that it has been compared to a very good drug like Navivolol, which has shown to be a drug of choice for people with sexual dysfunction. So it has become comparable, or even in some studies, it has surpassed the action of Navivolol. And even in congestive cardiac failure patients, the studies have shown that it is a worthwhile drug to be used for people with cardiac failure as well, compared to carvedilol.
Thank you very much, Dr. Haroon Aziz.